In America, a hospital visit does not end when you leave the hospital. Sometimes that is when the real machine starts. You thought you were treated by a doctor, but after the doctor leaves, your body becomes paperwork. A diagnosis becomes a code, a procedure becomes another code, a room becomes a charge, and one ordinary afternoon becomes a bill nobody can understand. This is not an accident. It is a system designed in layers. The first layer is the price you almost never see first. Hospitals have something called a chargemaster. It is a huge internal list of prices for services, supplies, rooms, drugs, tests, and procedures. One aspirin, one blood test, one scan, 1 minute in a room. Everything gets translated into a number. But here is the strange part. The first price is often not the final price. It is more like an opening move. Because if you have insurance, the bill does not go straight to you. It goes into negotiation. Long before you got sick, the hospital and the insurer already made a deal, not for one patient, for thousands. The hospital says, "This is what we charge." The insurer says, "This is what we agreed to pay," and the price begins to shrink. That reduced number is called the negotiated rate. It can be wildly different from the original charge. The same scan in the same city can have different prices depending on who pays. Cash patient, private insurance, Medicare, different doors into the same room. This is where the bill stops being medicine and becomes a maze. Then comes the document that looks like a bill but says it is not a bill. The explanation of benefits. It tells you what the hospital charged, what the insurer allowed, what the insurer paid, and what you may owe. It sounds helpful, but for many people it feels like being handed a map in another language, because your real cost depends on the fine print of your plan. First, the deductible. That is the amount you must pay before insurance really starts helping. Then, the copay. Then, coinsurance. That is when you pay a percentage of the allowed amount. And above all of it sits the out-of-pocket maximum, a number that sounds like protection, but only after you have climbed far enough to reach it. So even with insurance, the bill can still find you. And if someone in the room was out of network, the machine used to get worse. You could go to an in-network hospital, be treated by an out-of-network provider, and receive a surprise bill later. That practice became so common a federal law had to step in. The No Surprises Act now protects many patients from certain emergency and out-of-network surprise bills, but protection is not the same as simplicity. The maze still has doors. One door says, "Claim denied." Another says, "Prior authorization was missing." Another says, "The code was wrong." Another says, "This doctor was not covered." To the patient, it feels personal, but inside the system, it is mechanical. Codes in, rules applied, money redirected. The doctor may not know the final price, the nurse may not know, the person scheduling your scan may not know, and you, the person expected to pay, often know last. That delay is part of the power, because by the time you see the price, the care already happened. You cannot return an emergency room visit, you cannot untake a CT scan, you cannot negotiate while you are unconscious. The market begins after the choice is gone, and when people cannot pay, the bill changes shape again. It can become a payment plan, a collection notice, a phone call, or a quiet wait people carry for years. This is why medical debt feels different from other debt. Nobody comparison shops an ambulance. Nobody pauses a heart attack to check network status. Nobody wants to learn billing codes while they are afraid. But the system asks them to, and then it tells them the bill is their responsibility. Not because they understood it, not because they chose every part of it, but because their name is at the top. That is the trick. A system made by hospitals, insurers, employers, coders, contractors, and collectors lands as one piece of paper, and that paper says, "You owe." But there is one thing the paper does not say loudly enough. The first bill is not always the final bill. Hospitals can correct codes, insurers can reprocess claims, patients can ask for itemized bills, they can ask about financial assistance, they can appeal, and sometimes just asking why changes the number. That does not make the system fair. It only proves the number was never as solid as it looked. The frightening part is not that medicine costs money. The frightening part is that the price is often discovered after trust has already been given. You bring pain. They bring codes. You bring fear. They bring contracts. You ask, am I going to be okay? The machine asks, who is paying? And once you see that machine, the bill changes. It stops being a personal failure. It becomes evidence. Evidence that sickness in America often comes with a second diagnosis. The body gets treated, then the wallet gets examined. So the next time a bill arrives, do not just ask what you owe. Ask what machine produced the number, because once you see the mechanism, the paper loses some of its magic and becomes something colder, stranger, and more useful. A map of who had power before you ever saw the price.